I'm Aileen Deogracias. I am a pediatric occupational therapist. I own my own practice at Therapy Works in Lawrenceville, Georgia. I work mainly with children with special needs, autism. I'm also a feeding therapist. I'm a community ambassador for Feeding Matters, which I was going to go and do a little plug today just to kind of like show you where the website is and all that. But like I said, earlier we were talking, I'm with GOTA, with legislation and reimbursement and the political action committee, and I would love more people in my committee. It's always fun to see what's going on. So thank you.
You have a big day coming up in January, right? The 20th.
February, right? Is that February?
Yeah.
Yes. Actually, it's January.
Oh, it is in January?
Yes, we moved it to January. Legislative Day. Right. Oh, gosh. Thank you. We have Legislative Day on January 29th. It's usually a Wednesday, and that's the day where we go to the state capitol and we try and meet with our legislators. We had it's been really good the last few years, especially last year, since we were trying to pass the updated OT Practice Act. So that was, and we hope to see you there. It's always good to kind of just do grassroots lobbying. We have a lobbyist. I work with Tom Bauer, our GOTA lobbyist, and so he's kind of showing us how to maneuver legislation, but we could all do our part in reaching out to our representatives and just telling them about OT, and more often that you'll find that they have had experience with OT through their parents, through their kids, so it's always good to have that connection.
Do you know how long it usually is? Like, I know that it starts early. Do you know what time it ends?
We're usually done by 10:30.
Oh, okay.
Yeah. So what we do is, and we have like an agenda, but usually we come there. We arrive like around 8:30, and then Tom or I or Irma or whoever is there, we talk about what our legislative priorities are. Like, what bills are we trying to have our representatives support? Which, like last time, it was the Practice Act. This time, I think it's something about like the copay legislation, and there's a couple more, like putting telepractice. So it's usually about 2 hours. If you've already, you can request to see your representative. So with that's about 5 minutes, really. So it's usually done by 10:30. I'm going to talk about pediatrics and how it is to work in outpatient pediatrics, if there is an interest in pediatrics. So just a little about me. I'm an occupational therapist. I have been this is my 22nd year as an occupational therapist. I started in the Philippines. So I graduated from the University of the Philippines in 1997. I did outpatient pediatrics while I was there, and then moved here in 2006 with my family. So when I got here to Georgia, I did Babies Can't Wait. So that's our early intervention program, and that's pediatrics in the home. So we would go into the home, into the daycare, and it's and we see children from birth to 3. I had to move to California. It was around that time when there was like a change in Georgia Medicaid, and we didn't know if we were going to have a job. So I moved to California with my family and went into skilled nursing, and that was like a switch in my brain. Like, I've never seen adult patients before. I had to, like, at that time we didn't have Google, so you would say, like, do you know the hip precautions for this patient? And I'm like, what is a hip precaution again? And I am like, oh, you're not supposed to do that. But it kind of, the great thing about being an OT is that you could work in different areas of practice. And as a mom, I kind of just went with where my children were at that time. Skilled nursing was wonderful because, I had little kids. And then when my kids were in school, I said, like, let me try going into schools. And I did, and it was wonderful. And, now I'm back into pediatrics. So I am at Therapy Works, and Therapy Works is a pediatric therapy center. We're in Lawrenceville, Georgia. We're by where Sugarloaf Mills Mall is on, the Sugarloaf exit, and we have, it's a typical outpatient therapy center. So we have physical therapy, occupational therapy, and speech therapy, and it's kind of like, what do you call that? I don't want to call it a mess, although we are a mess. OTs are typically known to be messy, but we love collaborating with each other. Like, the physical therapist is there. We do, we can't do concurrent sessions just because it's again, a condition of participation for the insurance that we are contracted with, but we do a lot of collaboration, and we pride ourselves because we are really teachers to the families. We have grandma there, mom, dad, uncle. Now that it's the holiday season, we'll be seeing, more grandparents coming in for therapy. And, we teach them because therapy doesn't happen in a vacuum. That's our belief, that it's not just that 1 hour a week thing, because the child, there's like 24 hours in a day times 7, and OT only happens 1 hour. So how do you expand that? So you involve them, you teach them activities, you teach them how to play with their kids, you teach them how to reinforce, how to notice, say good job, say, and it becomes, it becomes like a partnership with the families. We are all, Therapy Works we are recognized as a feeding clinic. We see kids with what we call pediatric feeding disorders, and it could be as severe as a child on a G-tube or an NG tube, or somebody who has such limited food repertoire, like those kids that only eat chicken nuggets, or those kids that are unable to keep food down, or are losing weight because of limited food choices, or so we. It's typically speech therapists would see them, but I feel like occupational therapists are way more equipped. I mean, I don't want to put down my speech therapy friends, but because as OTs, we look at everything. We look at sensory, we look at mealtime participation, we look at how they use, the spoon, the knife, and the fork. We look at their fine motor skills. We look at their oral motor skills. It's because feeding is a lot more than just what happens in the mouth. It's an experience. It's like we're drinking, we're eating while we're having a meeting, and for it's very isolating for a child or their families or their parents if their child is not eating well, and that's what I kind of wanted to talk about, because there's not a lot of OTs that choose to be in feeding. It's scary. It's, when you have a child gagging and there you're like, ah. But it is very rewarding, and I feel like it is the true essence of what being an occupational therapist is, which is, we really are all about individuals participating. And again, eating is the baby's first interaction with the environment. It's, them being breastfed or them taking in milk is the first thing from the outside world that is introduced in them, and it happens in the mouth. And it should be automatic, that suck, swallow, breathe, and drinking, and you have a 2-year-old, so you know that that when he's hungry, is your baby a girl or a boy? So when he's hungry, you feel good that you are feeding your child and that he is fed well and he's healthy, and that's your role as a mother. So just think of those families where the moms are like, wow, my baby is not, I have to make him fall asleep for him to take the bottle. How stressful is that? And how often does feeding happen? It happens all the time. So those are the families that we meet, those families that that there's a lot more going on than just a child not eating. She is stressed. I have a mom that it is kind of triggering postpartum depression because she doesn't feel like she is adequate as a parent. So I know it's not simple. There's so many layers, and there's so many things intertwined to it. But yeah, that's it. And I was going to talk about Feeding Matters. So feedingmatters.org is a website. It's an organization. They have a website. They're based out of Arizona, and they are pushing for better diagnosis and identification of pediatric feeding disorders. We were talking about insurance earlier, and there are a lot of insurance companies that are not going to be paying for feeding therapy or intensive feeding therapy. I mean, these kids, we see them once a week or twice a week, and that's it. That's all we could bill for. But we would see better outcomes if we see them more often for a short period of time, like a short burst of intensive therapy, to help mom feel confident about feeding their child, and to help and to help the child eat, really to thrive. That's it's a matter of life and death. So they have a website where they have resources for families, they have resources for professionals. There's questionnaires on the website. I'm gonna go, I think I pulled it up. And I just, it's feedingmatters.org. I told them that I was gonna go and talk about them. Mm-hmm. And it's just resources for us as OTs. And
the people that started this, are they OTs?
There are a lot of OTs. Kate Toomey of the SOS, there's a certification program called SOS Feeding Approach, and she is one of the board members. And Aaron Ross, who is a speech therapist, is one of the board members here, feeding. But there's a lot of OTs that are members of, actually there's a lot more OTs than speech therapists. I was looking at them, and that's why I said it, I'd like to help talk about that. So they have questionnaires for parents, and they put in their date of birth of their child, and then a set of questionnaires comes up, with what is age appropriate, and then gives them that's a red flag, or that is appropriate for a 2-month-old, so just to kind of direct the parents, or give the parents the questions to ask their doctors, or what to tell their doctors when they go for their well visit. There's also a pediatric feeding conference, it's a virtual conference that's coming up. And there's resources here, where do you get special spoons, or where do you get, what are great toys to encourage eating, or what do you do when your child is rejecting the bottle, or just kind of resources for us therapists that are really helpful, and then a list of providers. So yeah, so that's it. Yeah. Any questions?
What do you think is the most frequently occurring side? I obviously don't work in pediatrics. Diagnosis that you see, and kind of the length of treatment.
I see a lot of kids with autism. It's when they talk about there's 1 in 66 births we actually see that, you know, there are, and some of them, they come in with, could be a sensory disorder, could be some behaviors, could be, you know, but I guess people are diagnosing early just so that they could qualify for services. So that would be a bulk of the children that we see. We also see a lot of kids, you know, like because we have speech therapists and we have physical therapists. There's a lot of like referrals to. They would come in with speech and language delay, and then the speech therapist would see red flags, you know, like the spinning or just. Some of them are tiptoe walking, some, you know, some sensory kids that, or would not sit down, or does not sleep, or does not do this. So that would be, you know, like the kids that we see, and we use developmental measures. Like I use the Peabody or the DAISY or the PD, and then we do reassessments and we do discharge. We either discharge them because they are showing age appropriate skills, or we discharge them to, you know, they're starting school, so, you know, they're triggering the IEP process, and we do still see them, but they kind of fall away. So it really depends. But yeah, we see a lot of 2s and 3s, because I feel like parents are more alert now to what's, you know, to kind of like delays. So yeah.
What would intervention look like for like the baby who had a hard time breastfeeding?
So intervention would be really with mom. It's a collaborative approach. How I use, I have to do the assessment first. So there is assessment tools that I like. I think it started in 2017. It's through the Feeding Flock group. It's a free, it's called like the Chomps or like something like that. But we would identify what's the problem. So for that child who is not breastfeeding, what is going on? Are there breathing issues? Are there, you know, is it a sensory issue? And then you kind of refer, like if it is like if you feel like it's a cardiac or a respiratory issue, then you refer, or then, you know, we would need them to go through a swallow study to make sure that, you know, there's no risk of aspiration. But so once they're cleared with all of that, and then we can intervene, it really would be collaborative with the mom. Her coming in during a feeding time, and, you know, she would feed a baby, and then we would look at, like, you know, how's the baby reacting. We've tried, you know, we've been doing like the Will Barger brushing protocol that usually works with some of the kids. We would teach them how to do infant massage. We would teach them how to try, you know, how to go through like different nipples, different formulas, all of that. So. Yeah, that's, we would teach mom how to kind of time the breastfeeding, how to not be frustrated with the baby, how to access, you know, and also how to access whatever community resources there are. So there's like the La Leche League, there's if they need referral to early intervention, we would refer them to Babies Can't Wait. We would refer them back to the doctor. So that's how it is.
Do y'all do swallow studies on all the kids before you intervene?
I prefer that they would have done the swallow study, just because if a child is silently aspirating, you want clearance. It's just a precaution, just to kind of get that out of the way, and they do get it done pretty easily at Showa. So. Yeah, we would also look at we would look at the weight chart. So see where, if there's been a drop in the weight, if there's, you know, what percentile they are in terms of, because that's going to help justify medical necessity, which is, yeah.
And how do you bill for it? Do you bill under, there's not a feeding code. So
we bill therapeutic activities, we bill self-care. That's how, I wish there was a feeding code. It would be maybe you could,
Helpful.
yeah. With the RA, maybe, looking at CPT codes that speak really to what OTs do.
There's
So,
been in the RA, because I was the speaker last 3 years, there's been a push forward for maternal infant health, mental health,
yes.
which, kind of segues with the feeding issues a lot, because sometimes kids have a lot of behaviors and the moms have behaviors too. I mean, every person has behaviors, and sometimes they don't mesh really well, and so then you have problems with the baby with attachment or maybe feeding,
Right.
or something like that. And so there's a group. In fact, Pfeiffer is involved in this group. She was a student at Georgia State also who's very interested in maternal infant mental health. And Apple Sepulveda out in California. Do you know Apple?
I do know Apple.
Yeah.
Yes.
Yeah.
And Barry.
Yeah, right.
I don't know them, but they are, I know about them.
So they've put forth 2 motions in the RA, and they want a position paper, but there hasn't been, there's so much of that information kind of intertwined in a lot of other position papers. But I think they're gaining some momentum. So I think it's interesting because that's like an area of practice, like an emerging area of practice for occupational therapy. And so we'll see where that goes, because they submitted, and Pfeiffer was one of the authors of the motion in the fall, and they tossed it over to the RAC, because the RAC, the Representative Assembly Coordinating Commission, the COP, the Commission on Practice, they're the ones that would have been assigned to write it. So they're evaluating right now whether or not there's a justification for putting forth the effort and the time and the money to put that paper together. But I think it's a really cool
Right,
emerging
yeah.
area of practice that we're all doing anyway, because we work with parents, but
Yes, and
to have it be something very focused for us to really sink our teeth into, I think is
that
really
is,
cool.
yeah, that's an area of need because, like I said, our clinic is open. Like, they come in and a lot of parents say, like, you're probably the only adults that I talk to. And so we know about their lives, we know about, because they look forward to coming to therapy, and that's, it's, I don't know what you call it. It's already low-hanging fruit for us for us therapists, because you're probably already doing it. Like, as a therapist, you're already intervening for the parents. So I would be very interested in what comes out of that. I attended, like, for the legislation part, I attended Georgia Voices for, so they have like a motion for social emotional and maternal health.
Yeah.
So I'll forward to you what their
I'm on
legislative.
their list and everything. I know Erica really well.
Yes, so
Do you know
Erica, yes, she invited me. We were at a.
Did you go to the fundraiser?
I did not. Yeah, so they have they sent. I don't know. You're probably part of it. What their legislative priorities are for the year. So there's a lot on.
I saw that.
Yeah, on social emotional health in Georgia. So yeah, that's. I feel like OTs have a lot of things to offer.
Yeah, Voices for Georgia's Children is a public policy advocacy group that's nonprofit, and they're all about advocating for children's rights and education,
Yes.
healthcare, and just general.
Yeah.
So, I had heard that there are some occupational therapists that work in the critical care unit of hospitals that work on swallowing with kids. Have you heard of anyone working in that?
I don't know specifically, but that would.
They work in the NICU.
Yeah, they could work in the NICU. Yes, there's a lot of occupational therapists working in NICU. Who is it?
Janine Craig.
Janine. Yes, I attended her talk at the 2 conferences ago. So Janine Craig was doing that. So yes, that would be.
Because there's like a certification, right? That you can get certified in swallowing.
Mm-hmm.
Yeah.
It's a specialty, so you can, or there's like continuing ed courses specifically for, practitioners in the NICU
AOTA has a feeding certification.
certification,
Okay, that's what
right?
it is.
Yes.
It's a specialty certification.
It's probably not specific to children, I wouldn't think.
I think it,
Although you probably could.
I don't know. I
Well,
feel
they're
like
doing
it
away
would-
with the portfolio.
Yeah, they are, right?
Yeah,
It's in Segway right now, right? I think it's gonna be launched in January. But, it's not a board certification, it's a specialty
A
certification.
specialty.
Okay.
Mhm.
But you're right, I don't know if it's just peds or peds and adults.
But you probably could, you know what, it probably wouldn't matter.
Yeah.
Yeah, probably
If
not.
it's reflective, then it
Yes.
doesn't really matter. It
Mm-hmm.
depends on your practice. So.
Right.
That's
Yeah.
right. Yeah.
Right.
Never thought about that.
Do you know the steps in swallowing? Because swallowing is really is a
Take
very
the SOS course.
Yes.
It comes in May.
complex
It comes in
thing.
May.
and-
There is a video that I show families. Oh, I don't know if I could connect to YouTube here, just to kind of get them in that, in that. That's a great question or a comment. There is it's an MRI of how someone swallows and how quickly things happen, because we kind of break it down and show you have to chew, you have to sweep with your tongue, you have to until you form a bolus for safe swallow, and then how does it really look like? So I was one mom asked me about it, and I said what, I'm gonna show you this video, so if you don't mind, I'll show you. I think I'm connected to the MRI of swallow, and it's here. I don't know if you could see it. So this is, oh, nope, hang on, sorry. Well, but it's very cool to just see. So you see where the oral, I don't know if you could see. Oh, hang on. It's someone's swallow study. Oh, there. How quickly that food transits through the esophagus. You don't think about it. When they're talking about when there's a delayed oral phase is when there's rejection, and there's because when you give the bottle to a child, there's that suck swallow reflex kind of just kicks in, but when it's not kicking in, it's it's a problem. But yeah it's
That's cool.
I think there's a better video of it, but you could see when chewing, and then it just goes through without him having to think about it. So that's where that breakdown is happening. We look at where is the breakdown happening. Is it in the oral phase? Is it in the chewing? Is it because the child doesn't have the adequate oral motor skills where, is the tongue getting in the way of the swallow, or is the child only doing thrusts? That's the most basic tongue movement, is going, moving in and out. You need to be able to do this, or do this, or do you have the core strength to, we don't feed a child that is not yet sitting with, with lumpy food. They need to have the core strength to be able to take it in, or they're going to aspirate. So, yeah, that's kind of the front view of it. That's how it goes. Yeah, there you go. It's just
Have you ever had a child aspirate during therapy?
cough. Yes. So when they cough, it means that they are able to reject the food. That's why we want to do the swallow study first, because you want to. Therapy is sort of because I'm a community therapist, my job is to make sure that the child is able to manage the food, but given that he is not going to aspirate because, but I am trained in, in first aid and all of that, just in case the child is, but sometimes you never know, you don't know. You don't know the silent aspiration. It's you just like, but you try and, like it's a precaution. It's just, yeah.
Well, thank you for sharing.
You're welcome. Thank you. I like to talk about not legislative stuff.
Make it entertaining.
Oh.